Hello, Simon Smale, Consultant Gastroenterologist. I thought today, in the light of the fact that I feel the sound quality on my original IBS videos was poor, I would repeat some of those. And I'm going to talk initially about irritable bowel syndrome and its diagnosis, and how a gastroenterologist or a general practitioner might reach a positive diagnosis of irritable bowel syndrome, which I think is very important in terms of going forwards and helping to manage that diagnosis constructively. So, in terms of making the diagnosis, the current guidance suggests that the patient ought to have had at least 6 months of abdominal pain or discomfort associated with bloating at times, although not always, and similarly there may well also be a change in bowel habit, which is another feature. Now, in terms of those symptoms, clearly they are symptoms which are presentations of many gastrointestinal diseases. And so it's important, first of all, that the chronicity is there. In other words, that it's been there for a long time, more than 3 months at least. Secondly, there are a number of things which might raise flags, red flags, and make us seek further investigation. Those are weight loss. So unintentional, unexplained weight loss should always give doctors consideration of further investigations. Similarly, rectal bleeding, whilst being a common condition, is sometimes a sign of more sinister pathology, and therefore consideration should be given to further investigation. It's not always necessary, and sometimes the type of rectal bleeding makes clear what the likely cause is, usually a problem with the anal canal, but sometimes that rectal bleeding can reflect more sinister problems. A family history, particularly in people who are reaching an age where cancer is more common, of either colon or ovarian cancer, and that should lead at least to consideration of whether further investigation should be indicated. And lastly, if people over 60 have new symptoms that have been going on for less than 6 weeks, that clearly needs further investigation. And some people would argue that the cutoff of 60 is perhaps a little old, but that's what the current guidance suggests. So in terms of investigation, obviously everyone should be examined, and they should be examined to make sure they don't have any abdominal masses, so the doctor should feel somebody's tummy or the practitioner. Equally, people should have a rectal examination to make sure they don't have any lumps or bumps in the inside of their rectum. And lastly, people shouldn't be anemic. People shouldn't have anemia in irritable bowel syndrome, at least unless they have another cause for it, which has already been diagnosed. In terms of investigations, everybody diagnosed with irritable bowel syndrome, before they reach that diagnosis definitively, should have a normal full blood count and either a normal ESR or CRP, which are markers of inflammation in the body. Now, usually, unless there are obviously other inflammatory conditions going on in the body, irritable bowel syndrome doesn't cause a raised ESR or CRP. And everyone should have a negative celiac serology. Now, that's a blood test, sometimes available as just a finger prick test these days, but that's not universally available. And that tells the patient whether or not they're allergic to a component of wheat called gluten. There's actually a small fragment of the gluten to which people become allergic. And if all of those tests are negative, then we can make a positive diagnosis of irritable bowel syndrome. The NICE guidance suggests a number of tests aren't indicated unless there are features that perhaps suggest another diagnosis. So ultrasound, unless people have got symptoms of gallstones with right upper abdominal pain after eating, associated with nausea and vomiting very often, people don't require an ultrasound. Similarly, if people have got classical symptoms of abdominal pain and change in bowel habit over many months, often years, and that's gone on for some time and their tests are normal, as we've discussed, then they don't need a colonoscopy or a sigmoidoscopy. Similarly, they don't need thyroid function tests unless there are other features of overactive thyroid, nor do they need stool cultures, because there are very few infectious causes of diarrhea that go on for 6 months or more. So with those positive features in the story, so abdominal pain, bloating and altered bowel habit, and a normal or a negative examination, and those normal investigations that we've touched on, full blood count, inflammatory markers and celiac screen, we can be confident that we have made a positive diagnosis of irritable bowel syndrome. Some people would do a fecal calprotectin, which is a stool test for inflammatory markers, and if there are features of weight loss, sometimes or deficiency in vitamins, a fecal elastase. But those are tests which are kind of extra and specialist, and not necessarily indicated in people with a classic story of IBS, where one can make a really positive diagnosis based upon the history and the examination findings, along with those standard investigations. Thanks for listening.